Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues, topic for today's discussion is update on hepatitis B. In today's lecture, we shall have a journey through guidelines towards a new paradigm shift. Bismillahirrahmanirrahim. Title of the lecture is Update on Hepatitis B, Journey Through Guidelines, a Paradigm Shift. Dear colleagues, we know hepatitis B is a major global health problem. According to WHO report 2019, worldwide prevalence of hepatitis B was 3.8%, with 1.5 million new cases and HBV pool of 296 million cases. 88% of the pool was residing in Africa, Southeast Asia, and Western Pacific region of WHO. Its associated mortality is 0.8 million deaths due to HBV-related liver failure, cirrhosis, or HCC. Dilemma is that only 10% of these 296 million were diagnosed and merely 2% were treated. The big challenge in the clinical practice regarding hepatitis B is that we cannot cure hepatitis B. We cannot cure hepatitis B. Instead, we can only control it. And that's the reason we are seeing new guidelines almost every year in an attempt to better control this lifelong disease. Let's start our journey through guidelines. Our journey will start from 2007 when Professor Anna S. FAROOQI published AACLD guidelines in 2007, and for many years these guidelines were followed and applied in clinical hepatology. Then in 2015, WHO published its guidelines, and in the same year, Professor Serene published the guidelines of a puzzle on the management of hepatitis B. Next year, Professor Noura, she published the updated guidelines of AACLD and hepatitis B. And the next year, in 2017, WHO again published the updated guidelines. In the same year, 2017, EASL published its guidelines, and these guidelines were very comprehensive, practical, and coined the terminology of hepatitis B virus infection for immune tolerant phase and immune control phases, and HBV hepatitis for immune reactive phase and immune escape phase. These guidelines also lowered down the threshold for viral load and widened the spectrum for initiating antiviral therapy. I personally liked these guidelines and used to follow these most of the time in my clinical practice. Then in 2018, AACLD again published its updated guidelines. Then we see a silence of almost 4 years when last year Chinese guidelines were published, followed by WHO guidelines this year on 29th March. So what we see, plethora of guidelines during last 9 years, almost 8 guidelines. And we do notice that after the initial guidelines by WCD in 2007, there was a gap of almost 7 years when WHO and APASR published their guidelines in 2015. Similarly, after 2018 WCD guidelines, again we see a 4 years silence when last year Chinese guidelines and this year WHO guidelines were published. But this time, these two guidelines, they have resulted in a paradigm shift. Now, what we see as a result of these two guidelines, a new paradigm, a paradigm shift in the management of hepatitis B. To better understand this paradigm shift, we need to go to some basic concepts. We need to revise, recall some basic concepts. First concept is cure of hepatitis B. What do we mean by cure of hepatitis B? Cure of hepatitis B can be categorized into 3 main types: partial cure, functional cure, and complete cure, depending upon the 4 parameters: HBV PCR negativity, E antigen seroconversion, S antigen seroconversion, and cccDNA. When these 2 parameters are achieved, the cure is called partial. And when the HBs antigen seroconversion also achieved in addition to these 2, this is called functional cure. And when all the 4 parameters are achieved, this is called complete cure. We know the current available treatment for hepatitis B, most of the times it gives us partial cure and very rarely the functional cure. For complete cure, we have to wait for the future therapies, and we hope that the future therapies will be giving us complete cure. A few words about the natural history of hepatitis B infection. Hepatitis B disease is an invasion of hepatocytes by cccDNA, which stays there in the hepatocytes lifelong. Acute hepatitis B recovers within 6 months, and at times the acute hepatitis B towards recovery follows the path of chronic hepatitis B. It goes through chronic hepatitis B and then recovers. By recovery, we mean functional cure, where HBs antigen becomes negative, E antigen seroconversion happens, DNA becomes negative, but cccDNA is still there. We know the chronic hepatitis B phase. At the chronic hepatitis B stage, it has fluctuating level of immune reactivity. It is characterized by fluctuating level of immune reactivity, which results in 4 discrete phases: immune tolerant phase, immune reactive phase, immune control phase, and immune escape phase. Heads of the arrows shows that these are interchangeable. Patient can go from immune tolerant phase to immune reactive phase, even back to immune tolerant phase, immune control phase, back to immune reactive phase, immune escape phase, back to immune escape phase, recovery so-called, and then again immune escape phase. So it's a to and fro movement of the patient's virological profile. We all know the virological profiles of these different phases depend upon what the phase it may be, but the point is that irrespective of the phase, cccDNA remains positive. And that's the reason I say hepatitis B disease is an invasion of hepatocytes by cccDNA, which stays there in the hepatocytes lifelong. HBV-related damage. How the hepatitis B causes liver damage? The HBV-related liver damage is caused by immune reactive phase and immune escape phase. These are the two phases which results in fibrous deposition in the liver because of they are the chronic inflammatory stages, and with the passage of time, when this inflammatory stage is not halted, there is change of fibrosis from F1 to F2, F3, and F4, which is called cirrhosis. So, longer the duration of these two phases, higher is the risk for developing liver cirrhosis and hepatocellular carcinoma. And remember that in immune escape phase, liver is already damaged because of the prior immune reactive phase. Please, you be with me on this diagram because my lecture is mostly comprised of on this diagram, and with this diagram, we shall be trying to understand the basic concepts and to see how the paradigm has been shifted by these two guidelines. What about the liver status at presentation? At presentation, depending upon the damage to the liver may be cirrhotic, it may be fibrotic, or it may be normal liver. So, the liver can be having three stages or three statuses at presentation. Either the liver is normal without any fibrosis, or it's a fibrotic liver, F1, F2, F3, or F4 or cirrhotic liver. What about aim of antiviral treatment? Why we treat this condition when I say it's a lifelong disease? First aim is to prevent liver damage. And this aim is achieved when we offer treatment to a liver which is normal, when there is no fibrosis happened. And the second aim is to halt or minimize liver damage. And this is when we treat a patient with fibrotic liver or cirrhotic liver, then our aim is to halt or minimize the liver damage. When to start antiviral treatment? This is another basic concept. Until now, these three conditions, when a patient is cirrhotic, it needs treatment. If the patient has got significant fibrosis, F2 and F3, again the patient needs treatment. And if a patient has got no significant fibrosis, either at zero fibrosis or F1 fibrosis, again this condition needs treatment. But conventionally, only two phases of this normal liver or liver without significant fibrosis was immune reactive phase and immune escape phase. That in these two phases, treatment has been suggested by all guidelines. That if a liver is normal, then the patient should be either in immune reactive phase or immune escape phase, or as the terminology was given by the EASL 2017, HBe antigen positive chronic hepatitis stage or HBe antigen negative chronic hepatitis B stage. This has been the basic concepts, or this has been the traditional timings to start antiviral treatment. So, when I say the paradigm shift, what paradigm shift? What do I mean by the paradigm shift? The paradigm shift has two components. The first component is that it has widened the spectrum for starting antiviral treatment. And this spectrum is in the when the patient has got normal liver or liver without significant fibrosis. We all know, no question about that the patient needs treatment when the patient has got cirrhotic liver or fibrotic liver. Patients without significant fibrosis, the treatment which used to be given only in immune reactive phase and immune escape phase, now according to new paradigm, all these four phases, immune tolerant phase, immune reactive phase, immune control phase, immune escape phase, all these four phases must be treated. Okay, so the second component of this paradigm shift is that threshold for starting antiviral treatment has lowered down. The spectrum, the horizontally it has been widened and the threshold has been lowered down. What do I mean by this? The traditional teaching was, the old guidelines, the guidelines prior to the Chinese guidelines, they were suggesting that if the patient liver is cirrhotic, PCR positive, only mere PCR positivity is important. The PCR should be positive irrespective of the viral load. The patient needs treatment if the PCR is positive. For fibrotic liver or patient with significant fibrosis, the minimal viral load required was 2000. That if a patient liver is having significant fibrosis, F2 or F3, then treat if the viral load is more than 2000 units. And if the patient liver is without significant fibrosis, then the teaching was to treat that if the viral load is more than 20,000. These were the thresholds, these were the viral loads till now, till 2023, that how we should treat these patients. When I say the threshold for starting antiviral treatment has been lowered down, it is the Chinese say, yes, the PCR which was needed to be positive in cirrhotic liver, no, there is no need for checking the PCR. If the PCR is negative, even then cirrhotic patient needs to be given antiviral treatment. This is the first level. Second, the patients with significant fibrosis, the liver with significant fibrosis, initial viral load was 2000, but now just mere positive PCR is enough. So the threshold has been lowered down, and this PCR positivity, it may be less than 2000. And similarly, patients with insignificant fibrosis, again, just a PCR being positive is enough. So the Chinese has lowered down the threshold for starting antiviral treatment. What about WHO? It has gone more. Again, the same, if the patient has got cirrhotic liver, PCR is not required, negative PCR. But if the patient has got significant fibrosis, the WHO says that even PCR is not required here in this state as well. With negative PCR, if the patient liver is having significant fibrosis, treat that patient. And the viral load which has been taken, it agrees with that in the patients with the normal liver, the viral load should be more than 2000. So the WHO as well as the Chinese guidelines, they have lowered down the threshold for antiviral treatment. If I compare these two end to end, in cirrhotic liver, both are recommending the same, negative PCR treatment started. Liver with significant fibrosis, WHO does not require PCR, and the Chinese wants just a mere positive PCR. The PCR must be positive, the qualitative PCR. And the liver without significant fibrosis, WHO recommends quantitative PCR, and the viral load should be more than 2000. Even the Chinese, they say just qualitative PCR and it should be positive. So here is the differences between these two guidelines and similarities between these two guidelines, and the way they have changed the paradigm, they have resulted in the paradigm shift. Okay, the treatment protocol, it has been very much given in a well way by the WHO. It says assessment for treatment eligibility must be done. Severity of liver disease, significant fibrosis, F2, if the EPI score is more than 0.5 or fibroscan value is more than 7, and it will be cirrhosis when there is clinical criteria of cirrhosis, patient developing HE, patient has got varices, varicose bleed, or patient has got portal hypertension, ascites, or clinical stigmata of the chronic liver disease, skin and all that. That is cirrhosis. In the absence of that, EPI score of 1 or transit elastography fibroscan's value of more than 12.5, this will define the patient has got cirrhosis. Second, ALT and DNA levels. WC says that the ALT upper limit of normal is 30 for men and boys and 19 for women and girls. For adolescents, this should be based on ALT more than normal on at least 2 occasions in a 6 to 12 months period, and HBV DNA more than 2000 according to WHO guidelines, and just detected according to the Chinese. So whichever guidelines you follow, these are the thresholds. Regarding the medical history, one should ask for the presence of co-infections, look for like HIV, hepatitis D or hepatitis C. Immune suppression if the patient is using long steroids, solid organ or stem cell transplant immunotherapy. If there are comorbidities like diabetes or diabetic metabolic dysfunction associated steatotic liver disease, or if there are any extrahepatic manifestations such as glomerulonephritis or vasculitis. And of course, the family history of liver cancer or cirrhosis must be solved because these are the risk factors for disease severity. Then the second component is general care measures, that counseling should be done on the lifestyle, diet and physical activity, alcohol consumption. Similarly, preparation for starting antiviral treatment must be there. Patient must be counseled regarding adherence, support, and risk factors for renal dysfunction and baseline renal functions are important. Similarly, preventive measures must be adopted by age-based screening of family and household members and sexual contacts with HBV vaccination of those negative. And then the patient-centered approach with discussion between individuals and their healthcare provider is important. And the treatment should be initiated and monitored either tenofovir or entecavir or TAFE in persons with osteoporosis or impaired renal functions or children and adolescents. And even the tenofovir as a drug of the HIV can be given if there is no access to TDF monotherapy. And once you start the patient antiviral treatment, every 6 months surveillance for alpha-fetoprotein and with alpha-fetoprotein and ultrasound, persons with cirrhosis or family history of liver cancer or cirrhosis, this is very, very important. And of course, the treatment response and disease progression must be checked by seeing the adherence on each visit. If on treatment, non-invasive tests for EPRI or transit elastography, ALT, BPCR, and monitoring of renal functions, creatinine is indicated. Okay, so coming to the new treatment algorithms, which these two guidelines have given, the Chinese guidelines and the WHO guidelines. The Chinese guidelines, the WHO guidelines, the aim is to overcome barriers in access to hepatitis B testing and treatment. There is scaling up testing and treatment towards the elimination goals and radical simplification of treatment criteria and care pathways. So in these two guidelines, we noticed that there is scaled up approach for testing and treatment, and they have suggested a radical simplified treatment criteria and care pathways. Let's see what's that. The Chinese guidelines, they say, and they tell us a few special scenarios if the patient has got liver cirrhosis, if patient has got liver failure, liver cancer, or if the patient has got immunosuppressant therapy or chemotherapy, or the patient has got receiving targeted therapy, then or the patient has got DS therapy for HCV, then start the patient without doing PCR. If these conditions are not present, then the qualitative PCR, the Chinese guidelines recommend qualitative PCR, do the qualitative PCR. If undetected, follow up the patient. If detected, then looking for the ALT. If ALT is raised, exclude other causes and then treat. But if the ALT is normal, look for these 4 conditions. If these are present, like family history of HBV-related cirrhosis or cancer, age more than 30 years, non-invasive or histological evidence of inflammation or fibrosis grade 2 or F2, and HBV-related extrahepatic manifestations, if these are present, detected PCR with normal ALT, treat. Otherwise, you follow them up. The WHO guidelines, on the other hand, it has given 4 options that if the patient has got these 4 options, treat this patient. First option is If there is significant fibrosis or cirrhosis, then irrespective of the DNA levels and ALT, the patient needs treatment. Second option is if the DNA level is more than 2000 and ALT level is more than normal, treat that patient. Third option is if there is presence of any of the following, then irrespective of the EPRI or DNA level or ALT levels, you treat that patient. And these are the co-infection with HIV, HDV, HCV, family history of the liver, cancer or cirrhosis, immune suppression, comorbidities, extrahepatic manifestation. And the fourth very unique option is in the absence of access to HBV DNA assay, persistently abnormal ALT levels alone can be treated with antiviral treatment. And if all these are not met, then of course follow. Just for the end-to-end comparison, I'm converting these options into the algorithm. Patient found to be base antigen positive. If these conditions are found, this cirrhosis, fibrosis, or all these, if these are found, treat without doing PCR. If these are not found, then check the PCR, and WHO says quantitative PCR. If the viral load is less than 2000, ALT is normal, no treatment, and monitor this group. If ALT is the PCR is less than 2000 but the ALT is raised, then treat that patient. This state. And if the PCR viral load is more than 2000, ALT is raised, treat that patient. But the WHO guidelines, they are silent on this end. When the viral load is more than 2000, ALT is normal, what to do? And this is when we compare end-to-end, again, H-based antigen positivity, special conditions which can be treated without doing PCR. Then doing the PCR, Chinese says qualitative PCR, WHO says quantitative PCR. Then again, almost the same pattern they are following. So, on the basis of these two, and going into the detail of these two, analyzing these two algorithms, I want to present a hybrid treatment algorithm for chronic hepatitis B. And what is that? We know that clinical guidelines, they are prepared after a very huge hard work, analyzing the data, discussions, experts' opinion, and then guidelines are produced. But at the same time, guidelines, these are tools, not rules. So guidelines are tools of management. These are not rules of management. So you individualize these guidelines into your clinical practice according to your patient. Just before going to the hybrid treatment algorithm, we know in cirrhosis, there is a data, and this is just 2022 study, that in patients with HBV DNA negative compensated cirrhosis, the cumulative incidence of HCC in patients not receiving antiviral treatment is significantly higher compared to those receiving antiviral treatment. It means that with cirrhotic patients compensated, if the PCR is negative and the PCR and you don't treat, the chances of HCC are higher. Another study last year, again, it is showing that in patients with compensated cirrhosis and on no treatment, low level viremia, that is less than 2000, increases the risk of HCC and liver decompensation as compared to those with undetectable HBV DNA. And these 2 points have been excellently taken by these 2 guidelines, the Chinese guidelines as well as by the WHO guidelines, that even you don't need to check the PCR, treat these patients. What about patients with insignificant fibrosis? I'll refer to the REVEAL data, a study conducted in 2004 and 5, published in 2006, the study from the Taiwan, where they had followed up the patient for 13 years. And what they found that the baseline viral load, hepatitis B viral load is directly proportional to the cumulative incidence of HCC and cirrhosis. These values, they were published in copies, and for the simplification and for better understanding, I have changed these into the international units. So if the viral load is less than 2000, the viral load which has been mentioned or taken as a criteria in WHO guidelines, if it is less than 2000, this is the group less than 2000, there is cumulative incidence of cirrhosis in 10%. So still the patient has got 10% risk that they can become cirrhotic. And similarly, the viral load is at less than 2000, again there is 3.6% risk that these patients can develop hepatocellular carcinoma. Similarly, on another old study which was from the Gambia, West Africa, and again, this study found that detectable PCR increases risk of cirrhosis by 6-fold and HCC by 12-fold. And when we see the viral load, if the viral load is more than 2000, it increases the risk of cirrhosis by 17-fold and HCC by 13-fold. But what about less than 2000 viral load, low level viremia? It does increase the risk of cirrhosis by 1.5-fold and HCC by 3-fold. Almost the same findings which the revealed data had shown. And if the patient has got positive E antigen, it increases risk of cirrhosis by 11-fold and HCC by 7-fold. So, level less than 2000, it's also not safe, it's risky. So, the hybrid treatment algorithm which I want to share with you or present to you is that if patient is found to be HBs antigen positive, WHO and Chinese both agreed that if the patient has got liver cirrhosis or the patient is receiving chemotherapy, targeted therapy or immune suppressant therapy, treat that patient without doing PCR. Our PCR may be done just for the follow-up of this patient, but for treatment initiation, PCR is not required. WHO added other conditions like patient with significant fibrosis, family history of liver cancer or cirrhosis, comorbidities, extrahepatic manifestation, and HIV co-infection. When these are present, then again start the patient on antiviral treatment without doing PCR. And Chinese, they have added HCC, patient with HCC, liver failure, liver transplant, they should be treated without doing PCR. So, if a patient found to be HBs antigen positive has these conditions, then PCR is not required and we need to treat the patient. No, when these conditions are not present, what to do? Check the PCR. And I personally is in favor of the qualitative PCR, is not the quantitative PCR for two reasons. Viral load less than 2000 is not safe. I shown you the data. Second, quantitative PCR and qualitative PCR cost issue. Quantitative PCR is almost 3 to 4 times expensive than the qualitative PCR. So I will do the qualitative PCR, and depending upon the qualitative PCR results, either the patient will be having detected PCR or not detected PCR, and then I will check the ALT, and with these two combo, I'll have 4 groups of patients: PCR positive with raised ALT, PCR positive with normal ALT, PCR negative with raised ALT, PCR negative with normal ALT. Remember, the WHO has recommended ALT upper limit of normal 30 for men and boys and 19 for women and girls. For adolescents, this should be based on ALT raised on at least 2 occasions in a 6 to 12 months period. Okay. Now, coming to this end, patient's PCR is positive, ALT raised, I shall treat. We should treat this patient. What about if the PCR is detected ALT is normal? If age is more than 30 years, there is co-infection with C and D, then this patient needs treatment. But if the ALT is normal with positive PCR and these conditions are not met, then defer treatment and monitor this patient. Coming to this end, when PCR is not detected, but the ALT is raised, treat this patient when no other cause could be found for this. But if the ALT is normal with negative PCR and the patient has got co-infection with hepatitis C or D, again, this patient needs treatment during the duration of treatment for C and D. And if the PCR is negative, ALT is normal, then defer treatment and monitor this patient. Dear colleagues, more or less the same treatment algorithm I have been following as a personal approach to treat my patients of chronic hepatitis B. Now having Chinese and WHO guidelines in front of my eyes, it gives me an opportunity to present this treatment algorithm in public. Indeed, the red highlighted component is the one where both the WHO and Chinese guidelines agree. Blue highlighted component is the one where the Chinese guidelines, it's according to the Chinese guidelines, and the green component is in accordance with the WHO guidelines. So I'll call it a GIFS hybrid treatment algorithm for chronic hepatitis B. And this brings me to the end of my lecture, an update of hepatitis B. Thank you for your very kind attention.